Hello, everyone. Welcome back to another session of our NCLEX RN Review Series. We are on day 61 out of the 90 days. And again, for those who are regular attendees, welcome back and thank you for being here with us. And for those who are new to the channel, we are inviting you to attend into the remainder of our classes. We still have a long ways to go. And we are also inviting you to join us in our NCLEX course. So kindly visit our website at Stancoast NCLEXcoaching.com and also click on the description box below. We have updated our library of on-demand videos plus the animated video series. Plus we have the NCLEX questions, about 3,000 NCLEX questions plus the 200 NGN test items. So if you are new to the channel and if you haven't subscribed yet, kindly do that, and also like this video if you find this series or if you find this lecture helpful. And also don't forget to share this to your friends who are also preparing for the exam. Now today, guys, we are going to tackle a very common topic that might be included in your exam, which is the CVA, or simply known as stroke or the brain attack. All right, take note of the words here and also the terms. Again, this is the cerebrovascular accident, stroke, or the brain attack. Now, take note, guys, that the stroke itself is a major health concern, and it ranks as the third leading cause of death in the US, and it is also the primary cause of neurological disability. And this is affecting the person's ability to function, and also will lead to so many disabilities that could affect for long term. And they're going to really require more healthcare needs, it will require them so much care in the long run. Now, as we're going to go through the discussion here, I'm just going to go through into the different types of stroke. And so you will see here that the stroke is subdivided into the two main categories, okay? We have our first category, which is the ischemic type of stroke, and this comprises about 85% of all the cases. And the ischemic stroke is going to be subdivided into subcategories, all right? Now let's talk about the atherosclerotic type of cerebrovascular disease, and this is going to cause about 20% of the incidence of stroke. And this is caused by the buildup of the plaque in the arteries, in the brain, blood vessels, and this will now lead to the reduction of the blood flow, of course. And with the atherosclerosis mainly affecting the brain, it can lead to a decreased blood flow to the brain tissue, or it could also be a cause of clot formation, and it will lead to the blockage as well. Now, please take note about the percentage here, 20% of the cases. Now, let's move into the next one, which is the penetrating artery disease, or known as the lacunes. This consists about 25% of all stroke cases, and this is going to involve those small blood vessels in the brain, wherein the tiny penetrating arteries will become occluded. And this will lead to small, deep infarcts, and they are what we call as the lacunar strokes. Okay, please take note of the word lacunar type of stroke. And again, this is caused by the occlusion of those small blood vessels in the brain, and this will lead to smaller, deep infarctions. Now, one of the contributory factor to the penetrating artery disease, or the lacunes, is the hypertension. If the person has chronic high blood pressure, then they are going to be at risk in developing the lacune type of stroke. And same thing with the diabetes mellitus as well. All right, we have that as diabetes and hypertension. So please take note, we are still talking about the lacunar type of stroke. Now, there is going to be a significant narrowing of the lumen of the blood vessels because the blood vessels are actually, the walls are being thick. They are going to thicken rather than thrombosis. All right. So here in the lacunar type of stroke, the walls are thickening. Wall thickening of the blood vessels. We are not talking about embolic stroke yet. All right. So here, the lacunar type of stroke is mainly affecting those smaller branches of the middle cerebral artery. That is what we refer to as the MCA. Again, the lacunar type of stroke will affect those smaller branches, the tinier blood vessels, the arteries forming the circle of Willis. Let me just put there the cow. Those are tinier blood vessels or arteries there. Now, when those arteries are kind of like thickened, as I'm talking about the walls, this will lead to a decrease in the blood supply to that particular brain tissue. Now, this time we're going to have to transition into the next type of ischemic stroke. We have here our cardiogenic embolism, which comprises about 20% of all cases. All right. So this is going to include those strokes that is caused by emboli, that is specifically originating from the heart itself. Now, what are these conditions that can lead to the cardiogenic emboli? What do you think? Well, we are going to recall here that most often the patient will develop the cardiogenic embolism due to the following, like atrial fibrillation. That's one, okay? Atrial fibrillation. Whenever the patient is going to, whenever they have uncontrolled AFib, they're going to tend to throw that clot into the cerebral circulation. So please take note about the AFib. It could be caused by a heart valve disease, mitral valve prolapse, those aortic regurgitation. Remember about those concepts that we have talked in the previous weeks. So we'll include that heart valve disease. Again, they're going to tend to have a sluggish circulation, and this will lead to the clumping of those blood causing the clot to form, and this will be pushed into the cerebral circulation. So another is the ventricular thrombi. And this is a time when the clots coming from the heart as well will travel to the brain. Now let's talk about another type of ischemic stroke. We have the cryptogenic stroke, which is going to be about 30% of all the cases. It simply means that there's no identifiable cause. Even if there are so many diagnostic tests that have been performed, it simply is not related to a specific cause. No identifiable cause. Let's just put it that way. No identifiable cause. That's why it's called cryptogenic. Hello, everyone. For those who just came into the class, welcome. I hope that you're going to stay with us all throughout this session. It's going to be a joy ride today. No identifiable cause. Let's just put it that way. All right. That is cryptogenic. Now, we also have the last one here. This is on other causes, and it will consist about 5% of all ischemic type of stroke. So it could be caused by conditions that will lead to increased clotting, or maybe there will be tearing of the artery wall, or maybe inflammation of the arteries, or in such a case that there is going to be vasospasm. Remember what we talked about yesterday about that migraine? Remember about that case whenever the patient is having that severe headache. And there was that question about what to watch for, what medication that should not or should be questioned if the patient has that headache, but it is severe in intensity. I think it was a case of a patient that has a prescription of aspirin, if I'm not mistaken. So here, migraine is actually part of this as well. All right. But this is, again, rare, only about 5% of all stroke cases. Again, other causes will include tearing of the artery wall, tears in artery wall, and then there's also that prothrombotic states wherein the person is, there is such condition wherein they have a higher risk in the clotting. All right. So please don't forget about the different subcategories in the ischemic stroke. We have the atherosclerotic. We're not talking about clots here. It's more of the plaque formation. All right. Here we have the penetrating artery disease, lacunes. This is mostly caused by the high blood pressure that is chronic. This is going to cause those small infarcts deep inside the brain and also associated with a diabetes. And then we have the cardiogenic embolism, and this is caused by those heart conditions like atrial fibrillation that is uncontrolled. Another is the valvular heart disease, and then the ventricular emboli as well. And then we have the cryptogenic stroke that is not quite understood. It is not closely associated with some factors. And then lastly, we have the other causes, which only consist about 5% of all the cases. Now, we're not done yet, really. The other category in our stroke, or the CVA, is the hemorrhagic type of stroke, and it's about 15% of all stroke cases. All right, so take note, with the hemorrhagic type of stroke, this could be in a form of intraparenchymal hemorrhage, wherein the brain tissue itself is bleeding because of a possible rupture of that artery caused by the hypertension. So let me put it right here. Intraparenchymal hemorrhage caused by arterial rupture due to hypertension. And then we also have the subarachnoid hemorrhage. Let me just shorten that as SAH. And the bleeding is actually happening in the space between the brain and also the surrounding membrane. And again, this is caused by a ruptured aneurysm. Alrighty. A ruptured aneurysm. Okay. So take note, guys, since this is fluid collection and also blood collection inside the brain, so this will definitely cause an immediate rise in the intracranial pressure. Even the ischemic type of strokes, this can also lead to an increase in the ICP when there is evolving stroke, if the patient is not treated timely. It can also lead to a high intracranial pressure. Now this time, guys, let's talk about the main clinical manifestations that you should be aware of. This is very basic. This is something that you can use in educating family members of those patients that suffered stroke, or even patients themselves. So they need to be taught about those major changes that they should watch if there is possible recurrence of their stroke. And so this is what we have as the B FAST. So what does that mean? Well, the B stands for the balance. So in a patient that may have a stroke, ischemic type of stroke, or may have a hemorrhagic type of stroke, they're going to have a problem in their balance. Also, their coordination is going to be impaired this time. Not just the balance, but also the coordination. So they will end up with incoordination. So what is going on really in the B, the balance issue? Well, if they have an imbalance, or if there is going to be incoordination, that simply means that the affected part of the brain is the cerebellum. Remember about the cerebellum? This is the portion of the brain that is actually controlling the coordination and balance, and also the brainstem. Okay, please take note about this specific areas in the brain that will be affected in a stroke. Not all type of stroke. It might not really affect the patients in coordination, but if the cerebellum and the brainstem are affected, then they're going to have this imbalance or incoordination. Now, if you're going to ask, what does the cranial nerve involve in this B, balance issue? Well, remember about the cranial nerve number 8. What is that? That is the vestibulocochlear nerve, where it actually will help in the patient's balance, the spatial orientation. And again, if the stroke is affecting the brain stem or the cerebellum, then definitely it can also affect the function of our cranial nerve number 8. Take note of that. Please don't forget. Now, let's talk about the next section, which is the letter E. That means that your vision will be involved. If a patient has stroke involving the eyes, then they're going to have a sudden trouble seeing in one or both eyes. This is going to be sudden visual impairment. So what is the brain function that are or is involved here? Well, this is going to be seen. If they're going to have visual issues, then this is associated with the occipital lobe impairment. Again, if there is visual impairment, then that simply means that the occipital lobe has been affected by the ischemia. Okay, please take note of that. Now, what are the cranial nerves that are affected whenever there is eye involvement or visual involvement? Well, take note about the cranial nerve number 2. What is in here? Take note about the optic nerve. This is the cranial nerve that is responsible for vision. And remember that a stroke affecting the optic nerve can also cause the loss of vision. Now, aside from the optic nerve, we have the cranial nerve number 3, which is the oculomotor. So what is in here? It is actually that cranial nerve that will control the movements of the eye and also the pupil constriction. So don't forget about this. Eye movement and pupil constriction. This is going to be affected as well. Pupil constriction. Now, if there is stroke-related issues affecting this nerve, it will eventually lead to that double vision. The patient will have diplopia, and they will also have difficulty moving their eyes. Difficulty moving the eyes. All right. So please take note about the cranial nerves involved when there is visual impairment. That could be cranial nerve number 2, the optic, or it could be cranial nerve number 3. And again, with the involvement of the occipital lobe of the brain. Now, we are going to continue with letter F. What is in letter F? This is the facial drooping, wherein there is going to be weakening of one side of the face, or it could be 2 sides. We don't know exactly where it's going to affect, right? But most often, it will be seen as one-sided or unilateral facial weakness. Now, what would be the specific area of the brain if there is going to be facial droop? Well, again, if the patient has that sudden weakness of the face or one side of the face, this is often caused by the involvement of the motor control areas in the brain. And one of those is the cranial nerve number 7. Take note about the facial nerve, cranial nerve number 7. You know that this is the cranial nerve that will control the facial muscles, right? So you're going to test the patient to do a smile showing their teeth, and you will be able to see if there is symmetry or there could be asymmetry. Please take note of that. You're going to ask your patient to smile, and take note if the one side would be still drooping while the other side is actually rising. So it could be the asymmetry or symmetry of the facial muscle. Let me correct this one right here. Let me change my pen to this color. We have blue this time. Okay, symmetry, or it could be asymmetry. Now again, if the stroke is affecting the motor areas of the brain, and again, or the facial nerve, it can cause one side of the face to have that paralysis. Or probably you will see that nasolabial fold right here. When you're actually smiling, it will actually rise up a little bit. But if the side of the face is paralyzed, if there is droop, it will not have that, okay? The face is asymmetrical. Now let's move on into the A. What is in letter A? This is pertaining to the arm weakness. So the weakness here is also sudden. This is going to be sudden weakness, and it can also involve numbness. So please take note of that. Not just the motor weakness or muscle weakness, it can also be accompanied by the numbness in one side. All right. So if you were going to ask, what is a specific area of the brain that is affected if there is going to be arm weakness? Well, let's take this section first away because this is getting busier. Let me erase all these. Okay, here we go. We're talking about arm weakness this time. So if you're going to ask where is specifically the part of that brain that is affected, well, this would be the cranial nerve that is involved, all right? And also the motor areas of the brain, including the primary motor cortex. So here the patient's actually, supposedly the patient's movements are controlled by the brain's motor cortex rather than the specific cranial nerves. So the function here is actually going to affect the muscles that can be directly affected by the brain damage. Now let's move on into the S. The patient will have speech difficulties. They will have sudden change in their ability to speak. They could be slurring. We call that as dysarthria. Slurring of speech. And this is going to affect the part of the brain that is specifically affected here is the language center of the brain. Where is this language center? Well, we have the Broca's and the Wernicke's areas. Remember those. Broca's and the Wernicke's. All right, we will elaborate more on that in the next slide because we're going to have to specifically identify those areas as well. Now, we have the cranial nerves that are affected here. Speech difficulty. Well, the cranial nerve that is also involved in our speech problem in this patient with a stroke, this could be associated with cranial nerve number 7, the facial nerve. Why? Cranial nerve number 7. Remember that the facial nerve also will affect the speech articulation. That's part of it. Facial nerve. And also cranial nerve number 10, which is the vagus nerve. And take note that this vagus nerve controls the muscles in the voice box, the throat, which is going to impact the patient's speech production. Again, vagus nerve and the facial nerve, because particularly the facial nerve is going to assist in the articulation of those words, while the vagus nerve is going to control those muscles, controlling the voice box. What else? The throat. Okay? So if there is involvement into these two cranial nerves, then definitely our patient will have difficulty in pronouncing or enunciating those words. Now let's have letter T this time. T, which stands for time to call 911 or to call the brain attack. So if the patient had the stroke in the home setting, or let's say in a nursing home or a assisted living, then the healthcare provider or whoever has found this patient to have stroke symptoms, they need to call 911. However, if the patient is in the acute care setting or is already in the hospital, maybe the stroke happened when the patient is admitted already. Maybe they came into the hospital for other reasons. Maybe they had pneumonia, or it could be hypertension. And then all of a sudden, their conditions probably had worsened and they developed this type of strokes. Then the nurse or whoever is involved in the care of this patient should call the brain attack system. And most acute care settings in the hospital will have this paging system, which will direct those members of the team. They are part of the brain attack team, and they will be paged whenever a patient has the brain attack or they have a stroke. So please don't forget about the brain attack team. And I work in a hospital that is also a stroke center. And so we've done this for almost 12, 15 years, maybe more than that. And so we have undergone with so many changes, more developments, more enhancements all throughout those years. And a lot of training actually will be involved, especially with the healthcare teams and also the nurses. Now, again, we really need you to make sure you know what is really in the BFAST in order for you to quickly address those manifestations and making sure that you can also alert your patient to make sure that they know what to report if they will have recurrence of their stroke. And again, the reason that we are wanting to emphasize this is to make sure that you are going to exercise. You're going to have to implement those immediate interventions necessary once you observe these signs and symptoms, because we want to preserve at least those remaining brain functions, right? So time is brain, okay? This is something that you should treat as a life-threatening medical emergency, just similar to a myocardial infarction. If they call myocardial infarction as heart attack, then we will also call stroke as brain attack, all right? Let's have our discussion into the specific areas of the brain. And this is according to the blood vessels that are involved supplying those tissues. All right, so let's have our first set of blood vessels that will contribute to the stroke. So if the type of stroke is causing a problem, especially the anterior cerebral artery, or known as the ACA. So where is that particularly in the brain? Well, the anterior cerebral artery, or the ACA, is somewhat right here. This is your anterior cerebral artery onto the in this section. It could also be found into the other side. So take note, anterior cerebral artery. So what areas of the brain will be affected if there is ischemia or maybe a clot that is lodging somewhere here? So what would be the part of the brain, or what brain lobe? Well, this can affect the medial portions of the frontal and also the parietal lobes of the brain. So take note, we are talking about the front side of the brain. Again, this can affect the medial, the intersection of the frontal and the parietal lobes. So what would be the manifestations here in this patient? if there is going to be ACA ischemia or ischemic type of stroke? Well, the patient will have a contralateral lower extremity weakness paralysis. So that simply means that if the patient has a stroke happening here because of a clot blocking the blood supply to the section of the brain, medial side of maybe the right side of the brain, right here, then the patient will have contralateral manifestation. So the patient will have sensory loss onto the left side. So that's basically it. That's why it's called contralateral. It will be the exact opposite side. Again, the manifestations will include weakness, paralysis. They will have sensation alteration. They will have partial, maybe complete sensory loss on the opposite side of the leg. Also could affect the sensation on the arm or the face as well. All right, but most often this will lead more sensation loss to the opposite side of the leg. Now, talking about the other manifestations here, if it is affecting the superior gyrus, frontal gyrus, what do you think will occur here? Frontal gyrus, superior section. The patient here will eventually suffer urinary incontinence. Please take note of that. They will have poor bladder control. Please take note about the specific area. Now, if there is going to be an involvement into the frontal lobe, well, this can cause the patient to have decreased motivation. All right? As we know that the frontal lobe is actually that area that can stimulate their will, their motivation. So if there is ischemia to the frontal lobe, then take note, your patient is not going to be so motivated in participating their care. And they will not have that spontaneity as well. Now, what else is going to be manifested if the patient is going to have the ACA ischemia? Well, there is going to be an effect into the prefrontal cortex of the brain. And here you will notice that the patient may have cognitive and personality changes. Again, take note about the personality changes. This is caused by the ACA affecting the prefrontal cortex. Now, let's move on into the next blood vessel involved. And this is going to be the middle cerebral artery. And this is a very common site of ischemia. Middle cerebral artery. This is what we refer to as the MCA. So where is that particularly? So this is a main branch of the artery inside the brain. It could also be right in this section right here. That's a large artery. Okay, so if there is a clot somewhere lodging into that middle cerebral artery, maybe the left or it could be the right, the person will end up with it could potentially affect the person's lateral section of their frontal. It could also affect the temporal, or it could be the parietal lobes of the brain. Now, if the patient will have this ischemia into the MCA section, well, what is going to occur here? The patient will manifest the contralateral hemiparesis, which is going to be into the exact opposite side. So if the patient has a clot somewhere into the left MCA, right here, well, they are going to manifest the paresis, hemiparesis, or the sensory loss into the right side. This is what we call as contralateral, exact opposite. Again, their motor function, their sensation will be greatly affected into the opposite side of the body. They also have some aphasia, wherein the patient will not be able to understand, or it could be unable to talk. It could be either expressive or it could be receptive type of aphasia. So please take note about those two forms. We have the Broca's area type of effect, which is basically in the frontal section of the brain. The patient here will not be able to talk. They will not be able to produce those words. And again, this is the Broca's area affected. Now, the other one is the Wernicke's area, which is specifically into the temporal lobe. So if this is going to be the area that is occluded, or if the blood supply is impaired into the temporal lobe, potentially the patient will have difficulty in understanding. They will not be able to comprehend what you are telling them. If they are given a piece of paper with instructions, they will not be able to understand those words that are printed. Notes will not be able to be interpreted by the patient because of the temporal lobe involvement. Again, comprehension is affected here. Again, guys, for those newbies, we are inviting you to enroll into our NCLEX course. So kindly visit our website, Stancoast, NCLEXcoaching.com, and also click the description box below for the link. Now, let's move on into another effect of the MCA ischemia. Well, it can also affect the optic radiations in both the temporal and also the parietal lobe. So what do you think would be the manifestation here? Well, when you have an involvement into this areas, then the patient will have a contralateral homonymous hemianopia. What is this? Well, this is going to be an impairment in the vision of our patient. So part of their visual field will actually be impaired. They will not be able to see that section. Okay, so let's have some examples of the right hemianopia. Right hemianopia. So here we're going to have to create these two visual fields. Supposing this is the left visual field, this is the right visual field. And the patient here, when they're actually looking into the visual field, they will have loss of vision in the right half of each eye. Again, right hemianopia. So each side of the eye, both the right or the left, this section right here that is shaded, they will not be able to see those objects. Half of their visual field is actually damaged. All right, they will not be able to see those objects that are in that area of their visual field. Now, what is the cause of the right hemianopia? This is caused by the damage of the left occipital lobe. Left occipital lobe. Or it could be caused by the damage to the left optic tract. As we know that the optic tract, basically, this will carry the information from the right visual field of both eyes, and the damage here can result in the loss of the vision in the right half of their visual, each eye, I should say. So that's about right hemianopia. Now let's have the left hemianopia this time. All righty. Let me erase this. Let's have left hemianopia. Color. Let me have the red this time. Left hemianopia. So, the vision loss will be affecting left half of each eye. So, half of each visual field will be lost, specifically the left side of each visual field, both eyes. So, they will not be able to see half of that. And again, this is going to be caused by the this is going to be caused by the right occipital lobe ischemia. and also the right optic tract. So again, the patient will have loss in their vision in the left half of each eye, and also because of the optic tract impairment, which is supposed to carry the information from both the left side, left visual field of each eye. All right. So we have here the right occipital lobe impairment will cause visual loss onto each eye, occurring into the left visual field. Now, this time we're going to talk about the superior hemianopia. So let's have that one as well. Superior hemianopia. So if we are talking about superior, we're talking about the top portion, upper half of each eye. Superior hemianopia. Left and the right. So half of the visual field, especially on the top portion, will be lost in this patient. Right? They will not be able to see those objects that will fall under that visual field. And again, this is caused by the inferior part of the visual cortex. It is the exact opposite. Since the problem here is on the top part, the cause will be on the inferior part of the visual cortex. Inferior part of visual cortex. And again, this is specifically in the parietal lobe of the brain and also the occipital lobe. Parietal and occipital lobes. Now, if you're going to wonder what's going to happen if there is inferior hemianopia, this will be the exact opposite. This will occur into the lower half of each eye. So let's change that. This time, inferior hemianopia. Let me erase this. Inferior hemianopia, then the loss of vision will be in the lower half of each eye. Okay, so the visual field will be lost in the lower section of each eye, or visual field, and this is caused by the damage into the superior part of the visual cortex. Superior visual cortex, and this is mainly affecting the occipital lobe. Again, we are talking about occipital lobe this time. And there's many others, like chondrotropia. So, but we're not going to go through all those more complex hemianopia. Those are more of the stroke nurse's certification, but we'll just have to identify those very common ones, especially if the patient will have impairment into, or let's say partial loss of their vision. Now, what are the other manifestations if the patient will have the middle cerebral artery ischemia? Well, you're going to expect that the patient might also have the gaze preferences, especially toward the side of the lesion, wherein this will specifically affect the frontal eye fields. There's also the dysarthria or neglect syndrome, especially if it is affecting the parietal lobe. So the person with the neglect syndrome, what is this? The patient will have lack of awareness of the opposite side of the space. Again, neglect syndrome. This is going to occur if the non-dominant hemisphere is affected. So especially if the person is right-sided, that is the dominant side. Then, or let's say, for example, if the person is left-sided in nature, left-sided, and If they will have a stroke into the left side of the brain, the left hemisphere, then this patient will be prone to have these neglect syndrome. They will have spatial neglect. They will have less awareness of the opposite side of the face, of the space rather. Spatial neglect. Again, they will now have a lack of awareness into the exact opposite of the space. No sound on my end. What is going on? Kindly check your device, Anita. Let me message her real quick. All right, trying to send. All right, guys. So that is about the MCA, or the middle cerebral artery. And of course, we're going to have to push through into the other arteries of the brain that will be potentially affected as well. So what if the patient will have an issue with the posterior cerebral artery? Again, we're talking into the backside section of the brain. So this is what we refer to as the PCA, posterior cerebral artery ischemia. So where is that in this picture? Well, this is right there, posterior cerebral artery, left side, or it could be on the right side as well, either. But in this photo, we'll tackle onto the left posterior cerebral artery. So let's get rid of this. So what do you think are the brain areas that will be affected if there is a PCA ischemia? Since we're talking about the backside of the brain. Well, those areas are the following. It could affect the occipital lobe. It can probably impair the inferior temporal, or it could be the thalamus. Take note of this right here, thalamus, or it could be the upper brain stem. Now, what are those manifestations if the PCA is involved? Well, the person will have the partial loss or loss of the same side of the visual field in both eyes. They will also have that contralateral homonymous hemianopia. Again, this is caused by the involvement of the occipital lobe, the primary visual cortex. What else? If there is going to be a blood supply issue into the occipital lobe, or it could be the inferior temporal lobe, then our patient can potentially have the agnosia. They will have issues in identifying those familiar objects that they encountered before. They probably will have issue in identifying the faces of their family members, even friends, colors. So these are things that can occur if there is going to be PCA affecting the occipital and also the inferior temporal lobe. They will not be able to identify those faces that they were familiar in the past. Okay. Now, what else? The patient may also manifest the severe persistent pain, especially if the thalamus is affected with its blood supply. So the patient will be complaining about a unilateral severe pain because of the involvement into the thalamus. Remember that thalamus is actually where we are going to process the sensation, the information and all those sensation. It could be the pain sensation. So with that impairment, the patient will complain about that one-sided type of severe persistent pain. Now, please take note that the patient may also manifest some other manifestations if it is affecting the left occipital lobe of the brain. So what are those manifestations? They will not be able to read what is written or whatever is printed on a piece of paper, or they may not be able to understand the calendar or whatever is written on the whiteboard. They will not be able to comprehend as well. Now, if the patient may have some issues with the occipital lobe, especially the left side, then they're going to have the agraphia. They will not be able to read. And even though if they have, actually, this is a graphia here, they will not be able to comprehend what is written for them. Even if they're writing, even if they had no issue in their writing before the stroke, they will not be able to comprehend what is given to them. If they have given those whiteboard instructions, whatever, in a piece of paper that is written, they will not be able to understand those things. Now, guys, let's move forward with another important blood vessel that could be affected in the ischemic stroke. We have the vertebral or the basilar artery. And where is that exactly? Right here in the drawing. So we have our vertebral or the basilar artery right here in this section. It will specifically affect the brainstem, the cerebellum, the occipital lobe, the thalamus. Take note, guys, if we have the brainstem, cerebellum, then our patient will potentially have the ipsilateral ataxia. So what is this ipsilateral ataxia? The patient will have uncoordinated movement. They will not be able to have that gait that they used to have. They probably would not be able to do this. When you're going to instruct them to have them touch your finger and then have them touch to your nose back and forth, they will not be able to maintain that kind of movement. Probably they're kind of like wobble like this. So there's no coordination in their movement. Now, what else is affected here? If the patient will have brainstem, cranial nerve effect, well, they will end up with the double vision, or known as the diplopia. Aside from that, they will also suffer from the difficulty in swallowing and also difficulty in pronouncing the words. And again, this is caused by an impairment in the brain stem, cranial nerve nuclei. So again, take note about the vision, the cranial nerve nuclei affecting the eye movements. They will have the double vision. They will also have swallowing issues, and they will have issues in their speech as well. Now, what else is involved here? If the person has involvement into the vestibular nuclei in the brain stem, this is going to cause the patient to have the vertigo, or could be balance issues as well. So they can easily fall this time. They will feel that their surrounding is spinning. All right. So the patient here is at great risk to fall. Now, what else would be manifested in this patient if there is an effect into the occipital lobe? So take note, if it's occipital lobe, take note of the visual deficits. So there will be a contralateral homonymous hemianopia. All right. The exact opposite side. Now let's move further here with the lacunar or small vessel disease. Well, this will specifically affect the pontine arteries or the pons. We know that if there is an impairment into the pons, the patient will have issues in their weakness. It could be weakness on the face and the muscles of the face. It could be the arms. It could be the leg. So it will be just one side. Now, what else? The patient will have difficulty in speaking, enunciating those words. They will have clumsiness as well. They will not be able to maintain that movement in one specific side of the hand or the arm. What else? The patient is probably going to have sensory loss if it's affecting the thalamus. And if this is involving the cerebral pathways or the internal capsule, they will have motor weakness and also incoordination, especially in the leg section of the body. And then you also have the occipital lobe involvement. Their visual fields will also be impaired. You will see that contralateral homonymous hemianopia as well. All right. Now, we're going to have to go through the different activities that you should be aware of, especially during the acute phase when the patient has the stroke. What do you think would be those things that you should know, that you should be able to carry out especially when you are the nurse taking care of a patient that just had the stroke, or if you are the ED nurse, if there is an admission for a stroke patient, what you should be doing? Well, of course, you're going to do that initial assessment. You're going to make sure that all those important data in detail should be collected from the patient. If they're still able to talk coherently, if they still have intact memory, or maybe if they are accompanied by the witness, or maybe a family member, or maybe a bystander, then definitely you have to get that history and make sure that the history will have the following: the time of onset. This is very important. When was the last time the person was observed well? Okay, so take note. You're going to ask the family member or the bystander, ask them when was the last time they've seen the patient that they were normal. Or let's say, when was the last time, or when was the exact time when they found the patient with the symptoms. Okay. What else? We're going to have to take note about their medical conditions. What are those comorbidities? That do they have stroke in the past? Do they have diabetes mellitus, or maybe hypertension? Those kinds of things. Also include in the medical history the medications that they are taking. Maybe they are taking antihypertensive meds. Maybe medications that are opiates, non-steroidal anti-inflammatories, or maybe they're taking blood thinners, anticoagulants, or are they taking anticonvulsants? So take note about those supplements as well. Are they taking those ginkgo biloba, garlic, which are known to be anticoagulants? They have an anticoagulant effect. They can cause bleeding. So you have to collect those necessary information as well. What else? We're going to have to do the neurologic exam. This is done rapidly and thoroughly. You should be doing the comprehensive neuro examination to assess the patient's mental state, their motor function, their sensation, cranial nerve function, and also evaluating their speech. So here, you're going to check their, wait a minute, level of consciousness. Of course, don't forget the GCS here. This is very important. Their motor function, their sensory function, cranial nerves, and also the patient's mental status, their speech, muscle strength, coordination. These are important assessment findings that you should carry out, or assessment tools that you should carry out into identifying the issues that patient may be having. Coordination along with the reflexes. So don't forget those. Now, another tool that we will be using to assess the patient with a stroke is the NIHSS. So what is this? This is a assessment that is going to be used by the medical provider for those nurses that are already trained to carry out the NIHSS. So this is something that a nurse should undergo training. They should be certified by the Stroke American Heart Association. They will be certifying the nurse. Let's say first 6 months, they will be renewing after they take the examination. And then after, I believe it will be 1 year. And then following, after another year, they're going to have to sit for another examination to make their certification current. So what is basically involved in the NIHSS? This is going to be a standardized examination that is going to assess the severity of the stroke. So the patient here will be assessed into those following sections. Part of the assessment here is to check for the patient's level of consciousness. All right. So this will check if the patient is responsive once the medical provider or the nurse will try to talk to them. Are they alert? Are they drowsy? Are they lethargic? So that's part of the examination. Another is the vision. So here you're going to check the person's ability to see those objects in their visual field. So you will have to cover one section of the one part or one side of one eye maybe, or the other eye. And so you will be asking, can you see my finger moving in front of you? And they will have to be asked as well if they can track your finger moving up or down, or maybe from one side to the next. And so this is going to check for the neglect, or the, not really neglect, but the homonymous hemianopia. All right. So what else? We're going to have to check the patient's sensation. We will compare if there is going to be numbness or could be absence of sensation in one side of the body. So you're going to have to check the patient's skin. You're going to have to use that safety pin to prick into the skin and have them tell you, is it dull sensation or is it sharp? It could be any part of the body that you should be checking here in order to compare if there is partial loss or there's really total or absence of sensation into that particular portion. Now, another is the speech. You're going to check the patient's ability to pronounce those very common words like mama, tip-top, 50-50. And you will be able to note that they have the dysarthria or slurring if they're going to be pronouncing way differently, okay? Or if you're going to check for their language, you're going to show them those photos or pictures of objects. You will have to show them maybe a piece of pen, maybe a stapler, or maybe a picture of a cat, and then you're going to ask them what they are seeing in that particular photo. So this is basically to check for their familiarity, or this will check for the patient's ability to process that photo. Are they still able to tell exactly if this is a cat? Maybe they will answer differently. And so that's going to be part of the testing. That is the language. Now, again, the higher the score on the NIHS, the higher the severity is actually going to be much worse for this patient. And so there is a massive effect of the stroke into multiple areas of the brain. If the score is 0 or maybe less than 5, then there is a high probability that the patient will have much more of a faster recovery, okay? The lesser the number, the lesser is the involvement in the brain tissue. Now, what else are we going to check in our patient during the initial assessment? Let's have the brain imaging. It could be the CT scan of the brain, or it could be the MRI, could be the non-contrast or contrast brain CT. So take note, guys, especially during the emergent period. The non-contrast type of CT is commonly used because we really want to capture if there is an ongoing stroke, okay? Non-contrast CT. And the reason for that is because if we're going to have to use the contrast type of CAT scan, this will require a lot of investigation. If the patient has allergy, or if there was adverse reaction from a previous exposure of the dye or contrast agent, and if there is no specific history, or if there's nobody that will be able to answer those questions, then it will not be safe for this procedure to be done, right? It can delay the treatment. So that is why the non-contrast type of CAT scan is often used. The same thing with the MRI. This is something that can be done if there is already screening that is completed. You have to thoroughly ask the patient's history, if they have any metallic implants, could be pacemaker, or it could be screws, it could be bolts, it could be plates. And so it will take time to actually do the investigation, and it will not help the patient during the acute phase. And so the MRI is usually done the following day, or if there is already enough information that is verified. Again, we will be expecting the non-contrast type of CAT scan for our patient. Now, please take note, guys, that the imaging studies will give us a better idea where the clot is exactly lodging, where it exactly blocks those arteries. All right. Now, what else? We're going to also perform the EKG, the 12-lead EKG, and this is to capture if there is any existing heart conditions, maybe acute MI, or if there is atrial fibrillation, wherein they could possibly have thrown the clot into the cerebral circulation. Yeah, that is why we're going to have to do the EKG, 12-lead EKG, to capture of those arrhythmias. Now, what else? We're going to have to check the patient's laboratory studies. It can comprise the following. The laboratory's test that we should be expecting will be the AccuCheck. You can do this at the bedside, and in the stroke centers, in the hospitals that are certified to receive stroke patients, it's already in their protocol to do the AccuCheck blood sugar testing right away. It doesn't need to have a doctor's order because it's part of the protocol. Whenever there is brain attack, you can immediately check the patient's blood sugar by doing the finger stick blood sugar. And this is to capture if the patient may have some hypoglycemia. Of course, if a patient has a hypoglycemic episode, this can also mimic those manifestations in a stroke, all right? Low blood sugar, it can mimic stroke symptoms. So that is why this is part of the brain attack nursing action. Checking the blood sugar right away. You don't have to wait for an order to do that one. Now, for the other laboratory testing, it can help if the doctor will order the following: complete blood count. This will give us a better idea on the white blood cells, the red blood cells, maybe the platelets. If there's an issue with anemia or clotting issues, maybe their platelet is way too high, or maybe if they have so high red blood cell count or hemoglobin count. Now, electrolytes can also be helpful in the diagnosis, especially if there is going to be maybe imbalances in the sodium. It can determine if there's any metabolic issues. Could be the hyponatremia, right? They could become comatose or so confused, because some confusion can also mimic the manifestation of the stroke as well. So make sure that you have those values. What else? Coagulation studies, creatinine level. Creatinine is also important because this can tell the healthcare team if there is going to be impairment in the kidney function. This can really influence the medication choices and also the overall treatment of our patient. Now, talking about the coagulation studies here, PT, INR, activated partial thromboplastin time. This will help us to have an idea, at least giving us baseline numbers. Is this patient taking any blood thinners? Maybe they're taking warfarin, or are they taking warfarin? Yes, Coumadin. And if they are not, and if they are assessed to have like ischemia type of stroke, then they are possible candidates in getting the TPA, which is the clot buster. Now, we also need to check about the cardiac enzymes. These tests will help determine if the patient has current heart attack. Those CKMB, the troponins, the myoglobin, those are important values as well that may contribute to the patient's stroke. So that's it pretty much about the needed information that will be ordered by the medical provider to establish the diagnosis of stroke. Now, this time we're going to have to talk about the different complications. So what are those complications? Well, it can progress into a much more severe of infarct, wherein the patient will have worsening of the brain damage. It might now affect those nearby structures in the brain. And so if there is that immediate damage to the brain tissue, Now it is going to be more extended into the neighboring tissues of the brain. Now let's talk about the cerebral edema. This is a common complication in all stroke patient. The swelling of the brain. This is going to occur, and this will also develop into increasing ICP. So it's very important, guys, that we will be able to know when exactly the brain attack occurred, because usually the brain edema or the cerebral edema, usually it can start within 1 to 2 days after the onset, okay? And it can last up till 10 days. Take note about the brain swelling after the stroke. It can start showing up within 1 to 2 days, but it can last up to the 10 days. And the reason for that's because of the breakdown in the blood-brain barrier, and this can cause accumulation of the fluid in the brain tissue. And again, cerebral edema, it can cause that mass effect. It can exert pressure into the nearby brain tissues. It can cause herniation of the brain and will also impair the blood flow to the other areas or other tissues in the brain. Again, don't forget about the increasing ICP. And all the more if your patient has the hemorrhagic type of stroke, right? So what do you think would be involved in the care of this patient with a cerebral edema? Remember about that hyperventilation in one of those test questions that we had in the previous day? When there is hyperventilation, rapid breathing that is induced, this can reduce the patient's ICP. It can also reduce the carbon dioxide level, CO2, and this can also help constrict those blood vessels. So again, this can reduce the patient's increasing ICP. Now what else? Mannitol can be one of those treatment if there's already increasing ICP, but we are not going to talk about the mannitol extensively this time. What else? If the patient has, let's say, hemorrhage, which is going to be a conversion, there are those patients that may have been treated by the TPA or the clot buster in the ischemic type of stroke. And I've seen those patients being transferred from the ICU after they receive the TPA. Well, they are going to convert into a hemorrhagic type of stroke, which is pretty sad. Most often when it converts into a hemorrhagic type of stroke, the patient will not be able to really regain brain function. And despite the treatment that are performed, the treatments that are performed for this patient with a conversion type of stroke, there's like a poor prognosis, and so they're going to end up with not getting. They will be transferred to the next unit, maybe the med-surg, and will be placed into comfort care. And most often this is the case, especially for those patients with the conversion. If there is massive bleeding after the administration of the TPA, then that's usually going to be the result. So you got to be careful in managing your patient, especially if you are treating them with a TPA. Now, what else? We got seizures. Because of the increasing edema inside the brain, this can also irritate those meninges. It can cause that increased ICP and eventually will lead to the seizures. Now, let's talk about the treatment, initial treatment of our patient. Well, we should identify the cause first. We have to make sure that this is done first thing, because if we are not able to do this, you will not be able to plan ahead. Especially if the medical provider did not have that information, how are they going to plan the care as well? No. So that is why we have to identify this by getting the history of our patient, making sure that we are doing the CAT scan as well to identify the extent of the stroke. It could be hemorrhagic, it could be ischemic type of stroke. All right. And of course, the medical history here is very important for us to identify if it's caused by a hypertensive crisis, rupture of the arteries in the brain, or it could be caused by the clot traveling into one of the cerebral arteries. Now, we also need to make sure that our patient's airway oxygenation is maintained, because this is definitely needed by the remaining functional brain tissues. IV fluids is also important to maintain the perfusion of the brain and also the other vital organs in the body. We also need to administer the thrombolytic TPA. Now, we are talking about ischemic stroke. All right? This is mostly caused by the clot. So, in most cases, if the patient will be a good candidate in receiving the TPA, we will be going through the medical history of the patient. All right? This is what we call as the clot buster. So is this something that will be given right away once the patient arrives in the ED, or if they are identified to have a ischemic type of stroke? No. The administration of the TPA will have to go through strict investigation. You have to ask family members. You have to check off that checklist. Is this patient above a certain age? Are they high risk? Or do they have high blood pressure that is uncontrolled? So there are those checklists that need to be filled by the medical provider to identify if they are not candidate to receive the clot buster, or if they are a good candidate to receive it. Then that would be the initial step before we are going to administer the TPA. So what is the TPA? This is going to help in lysing the blood clots. And this is effective, especially if the patient is still within the window. So what is that window? Well, if the patient's onset of the stroke is within the 4.5 hours or less, then they are going to be a good candidate to receive the TPA. There will be better outcomes if they are given the TPA within that time frame. Less than, mostly less than 4.5 hours after the onset of the stroke. So they will be a good candidate to receive the clot buster, along with the other criteria. Now, when is the time that the clot buster is not used? All right? When is it not used? Well, if the timing, if the onset of the stroke is unknown, then the TPA will not be ordered. A known onset of the stroke, specifically the ischemic, a known onset of signs and symptoms of the stroke. Or if the patient is taking blood thinners, anticoagulants, or those NOACs, the novel oral anticoagulants like Pradaxa, Plavix, what else? Maybe Plavix, Pradaxa, or like clopidogrel, anticoagulants, or the NOACs. So this will disqualify the patient from getting the TPA. Or if they have recent surgery or trauma. Recent surgery, or if they had trauma. So these are just a few examples of conditions that will disqualify them from getting the TPA because of their risk in bleeding. Oh, here's another one. Hypertension. Especially if the patient is running in the 180 systolic, 200s. They're not supposed to be getting this one as well. Now, this is a medication that is really high risk. This is only given by a critical care nurse that is trained to administer this medication. it's not given by a regular med-surg nurse. And again, this will depend on the institution policy, but most often this is a medication that can only be given by the ICU nurse or for those who have worked in the critical care setting. And this is going to involve 1-to-1 nurse-patient ratio, because this will require frequent monitoring of the patient's vital signs and also assessing the patient's overall neurofunction. All right, enough about the thrombolytic TPA. We'll also talk about the endovascular thrombectomy. So what is this? If the patient has a large clot lodging into one of those major arteries of the brain, then the thrombectomy, the removal is going to be done surgically to remove that large blood clot. And this is going to be done within 6 hours during the onset of stroke. Within 6 hours of stroke onset. So here, this is going to be effective if this is carried out within that time frame. Okay. Now, what else we have here in our treatment of the stroke? Aspirin is another one. Guys, aspirin here, let's talk about this. Aspirin is going to be administered to prevent further clotting. Again, this is also popularly used into those patients that may have the TIA, the transient ischemic type of stroke. Okay. The TIA, which is the minor type of stroke, that can resolve within just a few minutes, or it could be 2 hours. So the aspirin here will be recommended to be administered into this patient to prevent further clotting. This is going to be administered as soon as possible, ideally within the 48 hours of the stroke onset. Okay. Again, guys, if the patient has massive stroke and if they are taking the aspirin, this is one of the contraindications as well in the TPA use. Now let's talk about the general care of the ischemic stroke in the acute setting. Well, the general care will definitely include the airway protection. That is very important. Make sure that our patient is able to manage the oral secretions in order to avoid choking. They should not be allowed to eat or drink until the swallowing or dysphagia screen is assessed. Take note, guys. In neuro nursing, whenever they're going to manifest any neurological signs and symptoms, it is usually going to include NPO. All right? Why NPO? We still need to investigate if there is involvement in their swallowing. And how are we going to carry out this testing? The nurse will be doing the dysphagia screen. Once the patient is more stable, if everything is kind of settled already, if those diagnostic tests have been carried out, if those emergent interventions have been carried out, then we are going to test the patient's ability to swallow, including their gag reflex. So again, the dysphagia screen is very important before we are going to give them any medication orally or before we give them any oral fluids. Okay? Now, guys, if the patient may have a problem in swallowing the aspirin during the acute period, well, we also have a rectal aspirin. So this can bypass the PO medication, right? This can bypass the dysphagia screen. If they're not able to swallow really, then we are going to administer the aspirin rectally. That is a standard alternative. Now, what else? We are going to treat the patient as well. Check into their blood sugar, identify if there is hypoglycemia. If there is hypoglycemia, we need to treat that with maybe giving them an oral glucose, simple sugar, orange juice, if they're able to safely take the solution. Or if they are unconscious or if they are lethargic or drowsy, then we are going to give the glucose through the D50 or maybe glucagon to recover the patient or to make sure that their blood sugar will return to the normal range. Now, what else? We're going to also check the patient's temperature. This is very important, okay? Temperature management, because if the patient will have fever, this can increase the metabolic demands, especially in the brain. It will further cause brain damage into this patient. So we want to make sure that we are monitoring the patient's temperature consistently. Okay? We need to treat the fever as well with temperature lowering agents, or we can apply those cooling measures to treat their fever. Now, what else? We're going to have to keep their head in a good position. So what are those recommended head positioning? We are going to elevate the patient's head of bed by 30 degrees angle. All right, head of bed. And not just the head of bed, the head of the patient as well. Because I've seen so many patients that their head of bed is at 30 degrees angle, but the patient is slouched, or they are already sliding down into the middle part of the bed. So make sure that your patient really is positioned at 30 degrees angle with the head and also the head of bed. So not just the angle of the bed, but also the patient's head. All right, take note of that, because this is something that I've seen in so many scenarios. Now, let's take a look into the blood pressure control. This is huge. If your patient has hypertensive crisis, then this is something that needs to be treated, right? Especially if they are probably running 220 in their systolic, or maybe 120 diastolic. There is usually that general rule not to use the antihypertensive medications in the first 20 hours after a stroke unless the patient has a high blood pressure greater than 220. It depends on the protocols, but in the general guidelines with the SBP, general guidelines, it's not going to be applicable in everyone. According to medicine, there should not be administration of antihypertensive medications in the first 24 hours after a stroke unless they have high blood pressure greater than 220. And again, it could vary from other institutions. It could be greater than 180, or it could be greater than 180. I'll just include that. For the diastolic, it could be greater than 120 or greater than 130. It depends. And the reason for that, it's because if the patient is known to have hypertensive levels, let's say in the 180s all the time, if they have been running into that range most of the time, if we are going to treat that high blood pressure rapidly, if we're going to cause that blood pressure to go down so fast, this can also cause issues in the perfusion of the brain. So for example, if your patient came in with maybe 180 or maybe 220, and then you gave an antihypertensive medication and it went down to 110 or maybe 100, this is a sudden change in the circulation or the blood supply to the brain. So this can also affect the perfusion of the remaining functional brain tissue. So you got to be careful in the administration of the antihypertensive medications in a stroke patient. And I've dealt with this all issues. Parameters is really important in treating this patient with a complicated high blood pressure. Again, the parameters can vary from one institution to the next. You gotta follow what is ordered. But the general guidelines will usually there is an avoidance. There is a need to avoid giving them extensive antihypertensive medications during the first 24-hour periods if there is extensive high blood pressure readings for this patient before the onset of the stroke. Now, what else are we going to consider here, guys? We are going to talk about the prevention of the recurrence. For those patients that may have suffered TIA, they are really prone to developing another stroke within a week or within a month. And so it's very important that we are going to encourage modification in their lifestyle. We have to identify those risk factors, especially pre-existing conditions like diabetes, smoking, high cholesterol, obesity, hypertension. Those are going to need some modification. Okay. Now let's talk about the long-term care. There's many. As far as long-term care management, there is going to be much more of the lifestyle modification, the diet, I should say. Could be the use of the antiplatelet therapy. So that is one. Antiplatelet therapy. So we're talking about long-term here, guys. It could be statins. Maybe they're going to be prescribed those cholesterol-lowering medications. Or maybe they are going to receive the anticoagulation if they are known to have the AFib. Anticoagulation if they have AFib. So could be the Coumadin, or they might be getting the NOACs as well, the novel oral anticoagulants. Alrighty. So this time we're going to have to transition into the hemorrhagic type of stroke. So this is a condition that is also life-threatening. This will require admission to the ICU. The patient will require frequent, close monitoring, and this is going to require specialized care because of the severity in their condition. The intensive care will really provide the level of care that will allow continuous observation. All right. So what else are we going to expect here in the treatment of hemorrhagic stroke? Airway as well, breathing, circulation. Please don't forget that. We need to make sure that we are monitoring the patient's mental status this time, because if there is decreased oxygenation to the brain, their mental state will also be decreased, right? Make sure that they are able to perfuse the other vital organs in the body, and make sure that all those body organs, specifically the brain itself, will be getting enough oxygenation. Another is BP reduction. This is very important, especially in hemorrhagic type of stroke. If the patient is known to be hypertensive, we definitely need to reduce that, because if the patient has hypertension, it can worsen the bleeding. All right. And we don't want to lower the blood pressure drastically as well, because if we are going to do way too much antihypertensive administration, this can also reduce the blood flow to the remainder of the brain tissue. We don't want to cause worsening of the brain damage. Okay, so we just want to normalize their blood pressure reading. Do not cause hypotension to this patient. What else? We're going to have to manage their increased intracranial pressure, as we know that the fluids, the blood accumulating in the cranium, can also occupy a certain space. So it will elevate the ICP. We need to manage the patient's ICP with the use of the mannitol. Remember about that. Also, making sure that we are administering those needed medications. What are those medications that will be used in the hemorrhagic type of stroke? Well, we have the nicardipine, the labetalol, also the nitroprazide, especially for those patients that have the hypertensive crisis. Okay, so these are all powerful medications that can treat the patient's elevated blood pressure. Now, talking about the management of ICP, what can you remember here in the management of ICP? Make sure that your patient's head of bed is elevated greater than 30 degrees angle to reduce the pressure inside the skull. Also, the patient will require appropriate sedation, pain control. Pain control. There's also sedation of our patient, because if your patient is getting restless, this is going to contribute to the elevation of the ICP as well. Make sure that our patient is comfortable to prevent the ICP increase. What else? Mannitol. I mentioned that already. Okay, mannitol. This is to reduce the pressure. It will reduce the amount of fluids or swelling inside the brain to get rid of that fluid by allowing them to urinate. Okay. Now, what else is going to treat the patient's ICP as we are talking about the management of ICP? Another is the hyperventilation. This is going to lower the patient's CO2 level, right? I've mentioned this several times already. To reduce CO2, this can cause vasoconstriction, which will eventually lead to the decrease in the ICP. What else? Barbiturates. This is also known to reduce the brain activity and also will reduce the intracranial pressure. We also have the CSF drainage. What is this? Draining the CSF could be with the use of that ventriculostomy. Remember about that topic that we had regarding the brain injury? And we also need to monitor the patient's ICP with that device. Okay, remember that. Now, another management here to reverse the patient's bleeding is to administer possibly vitamin K. If they are taking the Coumadin, then we are going to give them the vitamin K. Or if they are taking the heparin, we will reverse that by administering the protamine sulfate. Okay, so these are the following agents to treat if they were using the Coumadin. And if they use the heparin prior to the hemorrhagic stroke, then the protamine will be used to reverse that drug effect. Or the known aminocaproic acid. Or the tranexamic acid. These are your medications to stop the intracranial bleed when they have used the TPA. Okay? If there is the conversion of the ischemic stroke into a bleeding type of stroke, then they can be given the aminocaproic acid. Let me rewrite that. I can't understand my handwriting. Hang on a second. Give me a few seconds here. Aminocaproic acid or the tranexamic acid to reverse the effect of the TPA. And there is another one, prothrombin complex concentrate. Okay, what is this? This is also used to reverse the effects of the warfarin. And this is to also combat or reverse the effect of the NOACs, the newer or novel oral anticoagulant. So this is a newer treatment to reverse the effects of the NOACs, prothrombin complex concentrate. And there are some more, guys. I'm going to have to finish off here. Aside from those medications that we had listed, the patient will also possibly be getting the administration of the steroids, but it's not really recommended this time. But what they might end up having as a surgical treatment here, let me put it right here, surgical treatment. They might need to have the evacuation of the hematoma. So this is huge. Evacuation of hematoma. This is going to be done rapidly. As soon as the patient is identified to have bleeding in the brain, this is going to be done to remove the blood clots from the cerebellum. And this can be a life-saving measure and may improve the outcomes. But of course, it will be dependent into the patient's existing medical issue, or if they have any pre-existing comorbidities. If the risk outweighs the benefits, then that would not be their route to go. Okay. But in most cases, guys, especially with the intracerebral hemorrhage, the bleeding inside the brain can possibly not be controlled easily, and so surgery is not usually beneficial for them and may not improve the patient's condition. And so this will really involve extensive education and also conversation by the neurosurgeon and also the patient's family to weigh those risks and the benefits. Okay? So before we're going to move on with our exercises, again, we are inviting you to enroll into our NCLEX course. So kindly visit our website at www.stancoast.com, or also click in the description box below. And for those who are new to the channel, we are doing this daily review sessions at 9 p.m. Eastern Standard Time. We still have more days to go. We're only on day 61. So we will be having another session tomorrow and the rest of the, I think the rest of the month. Okay. Let's have a first question of the day. Oh, we have those in my slides. Let's have question number 1. After experiencing temporary symptoms like ringing in the ears, double vision, and difficulty speaking, which left no lasting benefits, what treatment is the nurse likely to discuss with a patient? Let me reread the question. After experiencing temporary symptoms like ringing in the ears, double vision, and difficulty speaking which left no lasting effects, what treatment is the nurse likely to discuss with the patient? Is it A, surgery to clip a cerebral aneurysm, B, continuous intravenous heparin therapy, C, starting a low-dose aspirin regimen orally, or D, administering tissue plasminogen activator? What do you think, guys? Question number 1. The patient is experiencing temporary symptoms like ringing in the ears, double vision, difficulty speaking, which left no lasting effects. What treatment is the nurse likely to discuss with the patient? Most likely or likely. Will that be letter A? So let's have letter A. Surgery to clip a cerebral aneurysm. Is this appropriate? No, it is not appropriate. Our patient has the manifestations of transient ischemic attack. So this is a TIA, a temporary stroke that actually resolved. Okay? TIA. There is no need for us to talk to the patient regarding cerebral aneurysm clipping. This is not appropriate. This is only indicated if the patient has a known cerebral aneurysm. Okay? What about letter B? Continuous intravenous heparin infusion. Will that be appropriate? No. The heparin is not typically used to treat TIAs. The patient who will be getting the heparin is only indicated if the patient may have issues like DVT or pulmonary embolism, but not TIA. Indicated for pulmonary embolism, or could be DVT or acute coronary syndrome, ACS. Okay, don't forget that. We are going to expect the administration of heparin infusion continuously if they have pulmonary embolism, deep vein thrombosis, or they might have the acute coronary syndrome, but not on a patient with TIA. What about letter D, administering tissue plasminogen activator, the clot buster? Is this appropriate for the patient? Well, no. This is only intended for those patients that have ischemic stroke. Okay. Only intended if there is ischemic stroke diagnosis, but not for TIA. Okay, because the TIA can resolve on its own without any intervention. Okay, so our correct answer here is letter C, starting a low-dose aspirin regimen orally. This is the standard order that should be given to our patient once they have the TIA. Okay, this is recommended to reduce the risk of the stroke by preventing platelet aggregation. Prevents platelet aggregation. Aggregation. All right. So this is more of preventing future strokes as well. So let me add that. Future strokes is prevented by the administration of the low-dose aspirin. 81 milligrams aspirin. This is standard. Baby aspirin. We call that as baby aspirin, 81 milligrams daily. Post-TIA. So again, guys, your clue here in answering the question is to make sure you identify the symptoms. If you are not aware of the severity of the symptoms, then you will be answering the wrong option. You will be getting the wrong option if you don't know the severity or if the symptoms are that mild. So make sure you know this, okay? Make sure that you understand really the different manifestations so you can think about the appropriateness of that treatment. All right, that is for number one. Let's have number two question. A patient suspected of having a stroke is being admitted. Which assessment finding should prompt the nurse to speak with a healthcare provider before administering aspirin? Is it A, the patient is experiencing difficulty speaking, or B, the patient has a history of atrial fibrillation, or C, the patient mentions that their symptoms started with a sudden intense headache, or D, the patient has had short episodes of right side paralysis in the past? The scenario again is a patient suspected of having a stroke is admitted. But which finding should prompt you as the nurse to speak with the medical provider before administering aspirin? So which of the following conditions here will contraindicate the administration of aspirin? So your task here is look for contraindication. That is your task. All right, I'm seeing letter C's this time. That's a good answer. That is the correct answer. Letter C. Why? Letter C is basically it is a symptom of a possible hemorrhagic stroke. Okay? Sudden, intense headache. So, manifestation of hemorrhagic stroke. So you should not be administering that aspirin right away, because again, if the patient will complain about that intense headache that is sudden, this is a sign of, or a symptom rather, it's a symptom of hemorrhagic stroke. If letter A is your answer, the patient is experiencing difficulty in speaking, well, it's an expected finding, right, of a stroke affecting that speech center of the brain, right? So, for example, if there is dysphagia, difficulty in speaking, this can happen into the embolic or ischemic type of stroke. So aspirin will still be appropriate for this patient, okay? So speaking difficulties are common in ischemic stroke. Common in ischemic stroke. So this will not contraindicate the use of the aspirin. If the patient has a history of atrial fibrillation, this is a condition that is associated with the throwing off of that clot into the cerebral arteries. And this is going to be managed by the administration of the anticoagulants or the antiplatelet medication. So this is not going to be a condition that can contraindicate aspirin. What about letter D? The patient has had short episodes of right side paralysis in the past. In the past. So this is signifying that the patient may have had some embolic stroke in the past as well. And so the patient around this time with the resolved manifestations, they could get the benefits of taking the aspirin to prevent the ischemic events. All right. So this is not a contraindication. So our correct answer here is letter C rather. Alrighty, let's have number 3. A patient suspected of having a stroke is being admitted. Which assessment finding? Oh, this is the same one. Let me fast forward. 4. During a shift report, the nurse learns that a patient has a blockage in the left posterior cerebral artery. What symptom is the nurse most likely to encounter? So we are dealing with a patient that has a blockage to the left posterior cerebral artery. Posterior circulation. Is it trouble speaking? Or will this be disorientation or confusion? Or is it C, problems with vision? Or D, impaired decision-making ability? We are talking about left posterior cerebral artery blockage. So remember about those areas of the blockage that I talked about earlier. All right, I'm seeing no answer yet, so I will start. Let's have letter A. Trouble speaking. What is this? This is also referred to as dysphagia. Dysphagia with an S, not a G. Dysphagia is actually trouble speaking. Now, this is more associated with the middle cerebral artery type of stroke. Remember? Expressive aphasia. This is the middle cerebral artery. This can affect those areas that control the speech and language. Speech and language. So it's not going to be seen in a patient with the posterior cerebral artery type of stroke. So remember about those areas of the brain. So don't forget about those, guys. What about letter B? Disorientation or confusion. Disorientation or confusion. Well, this is incorrect as well because disorientation and confusion can result from ACA, anterior cerebral artery ischemia. And remember that when there is arteriocerebral artery occlusion, this can affect the frontal lobe. Right? Frontal lobe. So if you are worried about the confusion, you gotta have to think about the frontal lobe. Confusion, disorientation. All right. What about letter D, impaired decision-making ability? Is that correct? Impaired decision-making ability? Well, the patient's judgment is also linked to the frontal lobe dysfunction. This is frontal lobe effect. Again, an occlusion in the ACA, anterior cerebral artery. Okay, so this will affect the frontal lobe of the brain. This can impair the patient's ability to make decisions. All right, so we don't have any other answer but letter C, problems with vision. Remember I said earlier about occipital lobe of the brain? This will include more on the visual issue. Do not forget that, guys. Impairment in the vision will be mostly associated with occipital lobe ischemia. And this is affecting the posterior cerebral artery. Okay? Don't forget that. Don't forget that. This is very basic. Occipital lobe of the brain. Yeah. All right. Remember always, occipital lobe, you gotta worry about the patient's vision. Right? So I cannot emphasize this enough. Occipital lobe, if there is ischemia to this section of the brain, then think about visual issues. Those homonymous hemianopia, yeah, or partial loss of vision. Okay, let's have number 5 this time. A patient with suspected stroke has been unable to speak for 3 hours and their blood pressure reads 175/92 mmHg. Which medical order should the nurse question? Is it A, elevate the head of the bed to at least 30 degrees, B, administer normal saline IV at 75 ml per hour, or C, begin labetalol infusion to maintain blood pressure below 140/90, or letter D, give TPA IV following the established protocol? Which medical order should the nurse question? Your patient's blood pressure is 175/92. So which of the following orders you should question? All righty. Keep coming. If the patient's blood pressure is not controlled, mostly greater than 180 or greater than 200, those are the extreme numbers that you should pay attention, especially with the TPA. So let's have letter D this time. Give TPA intravenously following the established protocol. Well, this is going to be an incorrect answer. If the patient is still within that therapeutic window, let's say 4.5 hours after onset, or within 4.5 hours, then they are qualified to get the TPA according to the protocol. If the patient is within the therapeutic window, and if they're going to meet the criteria, then administration of the TPA can be possible for this patient. This is not going to be a contraindication following the established protocol. And take note about the blood pressure here, 175/92. This is something that can be easily controlled. It's not one of those 200s or 180. So consider that one. So this is going to be incorrect. We are looking for that answer or option that is supposed to be questioned. All right. If we are going to answer letter A, elevate the head of the bed at least 30 degrees. You think this will be a bad intervention if we are elevating the head of the bed? Actually, this will reduce the ICP. It will facilitate the drainage, venous drainage. It will promote better cerebral perfusion without compromising the patient's safety. So we are going to eliminate this one. This is a good order or good prescription. What about letter B? Administer normal saline at 75 mLs an hour. Is this something that you should question? Well, it is incorrect as well, because at this point, when the patient has the stroke, we also need to maintain their fluid balance. This is very important in managing their perfusion. Okay, it will prevent further ischemia. So we will eliminate this one as well. And so we are left with letter C, begin a labatoral infusion to maintain blood pressure below 140/90. Remember what I said earlier regarding the treatment of the hypertension? During the acute phase of the ischemic stroke, the high blood pressure is going to be very necessary to sustain the cerebral perfusion. We don't want to aggressively reduce the patient's blood pressure. Remember I said that earlier? Yeah, that is the answer. Okay, let me emphasize right here. Acute phase of ischemic stroke. We should not aggressively lower or reduce the patient's blood pressure. All right? Do not aggressively reduce the blood pressure. Because the reason for that is when you are doing that to the exact opposite, right? The patient has been hypertensive. If you are going to control the blood pressure so aggressively, when there is now rapid decline or rapid lowering of the patient's systolic, diastolic blood pressure, this can also reduce the blood flow to the brain because they're already used to the high blood pressure. And so when the patient will have that disruption, if they are going to receive the medication too aggressively, then they're not going to be able to receive adequate amount of blood, oxygen to the injured area of the brain. Okay? Do not aggressively reduce the blood pressure because it can also worsen the blood flow. To prevent worsening, here we go again. Prevents worsening of low perfusion. Okay. Please remember this, guys. This is very important. Yeah, it was quite difficult to grasp when before the hospital that I worked with before we got accredited as a stroke center, orders were like just all over the place. I mean, the physicians were just doing their own thing. It wasn't really that kind of a standardized protocol in every patient that had stroke. And so by the time when we were accredited as a stroke center, then everything was put into place. We have those parameters that we should be following in such a case that we should not cause harm to our patient, especially in a hypertensive patient, okay? We don't want to reduce the blood pressure so aggressively because they are already used to have that high blood pressure. All right, we are going to normalize though, at least lower them at a certain level, but to not lower it so rapidly. Let's have number 6. A patient comes to the ED with the symptoms of ischemic stroke and will receive TPA treatment, what should the nurse do first? Is it A, ask the patient about their current medications? Is it B, perform a complete health history and assessment? C, determine when the stroke symptoms began? And D, check if the patient has any upcoming surgeries. A patient comes to the emergency room with symptoms of an ischemic stroke and will receive TPA. What should the nurse do first? Is it A, ask the patient about their current medications? B, perform a complete health history and assessment? C, determine when the client or when the stroke symptoms began? And D, check if the patient has any upcoming surgeries. What you should do first. Your answers, please. All right, I'm seeing letter C's this time. If you had answered letter A, ask the patient about their current medications. It is a good question. I should say it is a good question, but it's not the primary question that we should be asking to this patient. All right. It is very important to really gather the information regarding what medications that they are currently taking. Maybe it's a prescription or it could be the supplements, but this information is secondary to determining the time of onset. So we should be asking this question first. The answer is letter C. Determine when the stroke symptoms began. That is the correct answer. Because if the patient is already out of that window period, the 4.5 hours, then the TPA treatment will no longer be effective. Remember this one. The 4.5 hours of window. This is the time when you are going to ask them the last time when the patient had been normal, or the time that they were observed to developing the manifestations of stroke. Onset of stroke symptoms. Not 6 hours, AJ. Not 6 hours. 4.5 symptoms. 4.5. No such thing as 6 hours. It's not going to benefit the patient. Okay? The standard is within 4.5 hours. It may have changed maybe lightly recently, maybe not. But this is the standard hours here, 4.5. Now, if you had answered letter A, or letter B rather, perform a complete health history and assessment, well, if you're going to do that in place of letter C, then you are delaying the treatment. Okay, make sure that you do letter C first. If you check if the patient had any upcoming surgeries, this is not going to be relevant in the investigation, because our goal here is to really determine the time frame, when exactly the patient was last seen normal, or the time that maybe I had misspoken. So maybe I've had misspoke about the time, but it's 4.6 hours, or 4.5 rather. 4.5 hours. So guys, we are going to check first the stroke symptom. This is the onset. So make sure that you have identified that first. Okay? Within the 4.5 hour period. Let's have number 7. A patient arrives in the ER with weakness and on one side of the body and slurred speech that began 2 hours ago, with a history of several TIAs. The nurse prepare for A, surgery to remove plaque from arteries, B, balloon angioplasty of the carotid artery, or is it C, starting a continuous IV heparin infusion, or D, infusing tissue plasminogen activator? A patient arrives in ER with weakness on one side of the body and slurred speech that began 2 hours ago with a history of several TIAs. The nurse prepares for A, surgery to remove plaque from arteries, or B, balloon angioplasty of the carotid artery, or is that C, starting a continuous IV heparin infusion, or will that be D, infusing tissue plasminogen activator, or TPA? With a history of several TIAs. That's not a good sign. If a patient has several TIAs, then a possibility of a worse stroke is probably going on in this patient. So if you answered letter A, surgery to remove plaque from arteries, is this indicated? What is this procedure? This is what we call as the endarterectomy. Endarterectomy. The removal of the plaques from the cerebral arteries. Carotid artery, should say. Okay? This is going to be done during the acute ischemic stroke, but it will require more time, especially that you have to be involved in the preoperative evaluation of the patient. This is not going to be the immediate action. Okay? Not typically, I should say. Not typically done during acute ischemic stroke. Not typical procedure during the acute ischemic stroke. So we will eliminate that. What about letter B? Balloon angioplasty of the carotid artery. What do you think about that procedure? Another procedure that is not a common emergency treatment for an acute ischemic stroke. It might be considered in chronic stenosis, but it's not part of the immediate treatment. So that's why we're eliminating this one as well. What about starting a heparin infusion? Will this help? We know that the heparin is only going to prevent clots, right? Or prevent growth, or it will prevent the growth of the existing clot lodging into that cerebral artery, but it will not dissolve the clot. So that's not the answer as well. Does not dissolve the clot. So we don't have any other option but letter D, prepare for the administration of the tissue plasminogen activator, the clot buster. Okay? Our patient that has a history of several TIAs are actually going to be probably developing that ischemic stroke already. Especially that the patient now has weakness on one side of the body, and they also have the slurring speech that began 2 hours ago. It is not resolving. Okay, take note about the manifestation of this patient. It did not resolve. It stayed for the duration. We should prepare the administration of the TPA. All right. So the correct answer here is letter D. Yes, that's correct, AJ. Heparin versus TPA. This is a clot buster. This is only going to prevent blood clots. It doesn't dissolve blood clots. It will also prevent growth of the blood clots. Okay, so I want you to C, the differences between the two medications. The heparin will not be useful in a patient that may have an ischemic type of stroke, maybe an embolic type of stroke. It will not treat the patient's condition. All right, let's have number 8. After thrombolytic therapy for an ischemic stroke, what is the primary focus within the first 24 hours? Is it heart rate? Is it B, respiratory rate? C, blood pressure? D, body temperature? After thrombolytic therapy for an ischemic stroke, what is the primary focus within the first 24 hours? Is it heart rate, respiratory rate, blood pressure, body temperature? Okay. What is the primary focus for this patient? After thrombolytic therapy for an ischemic, within the first 24 hours, let's have letter A this time. Will our heart rate be a crucial vital sign that you should consider in this scenario? Heart rate, we know that heart rate monitoring is important, but it's not the primary focus in the first 24 hours. Our concern here is the complication about the TPA therapy. So the concern in this scenario is the complication of TPA therapy. This is what you should be looking for, which is basically the bleeding. So if your patient may start to bleed, then you gotta monitor the patient's blood pressure. That is the correct answer. All right. You should be monitoring the patient's blood pressure and make sure that the patient's BP is well controlled. Again, controlling the blood pressure during the TPA therapy is very crucial. We don't want the patient's blood pressure to skyrocket, because if it does that, it can lead to the rupture. Okay? Blood pressure should be controlled. All right? Should be controlled to prevent rupture of blood vessels. Okay? BP control, guys. That's the key. If you had answered letter A, it's not as crucial compared to letter C. Respiratory rate is also important, but since we are looking for the complication of the TPA, which is the bleeding, then this is a secondary assessment. Temperature elevation is not really as critical compared to the blood pressure monitoring. This is our choice this time, letter C. All right, let's answer number 9. For a patient with a stroke affecting the right side of the brain, the nurse should plan interventions for A, limited physical movement on the right side of the body, B, safety risk due to unawareness of impairments and impulsivity, C, problems with speaking and understanding language, D, emotional issues like depression due to disability. Number 9, for a patient with a stroke affecting the right side of the brain, the nurse should plan interventions for A, limited physical mobility on the right side of the body, or is it B, safety risk due to an awareness of impairments and impulsivity, C, problems with speaking and understanding language, and D, emotional issues like depression due to disability. Your answer? All right, while waiting for your answers, we'll have letter A this time. Limited physical movement on the right side of the body. So what is this? Our patient has a stroke affecting the right side of the brain, the right hemisphere. Remember about the contralateral effect. Exact opposite. So, if the patient has a right-sided hemisphere stroke, what do you think can happen in this patient? Right-sided brain ischemia. Okay. So, remember that it has a contralateral effect. The patient will develop manifestations such as left-sided hemiplegia, left-sided hemiplegia, weakness to the left side because of the contralateral effect. Contralateral. What else? Right? Right hemisphere. So if you answered letter A, limited physical movement on the right side of the body, this is wrong. But again, this will affect the left side instead. The word right side makes that option wrong. What about letter B? Safety risk due to unawareness of impairments and impulsivity. Letter B. Remember, guys, that with the right-sided hemisphere stroke, they will have left-sided neglect. Okay? They will also have the impulsivity. That's another effect of the right hemisphere. Impulsivity. We are talking about the right side of the brain. There is going to be a reduced spatial awareness. This is a very common question in the NCLEX. Reduced spatial awareness. They will not be able to control their movements. I mean, they would not have that judgment regarding their limitation. Okay? They would not be able to tell how dangerous what they're doing, climbing out of bed, even though they have the limited activity, or they had the motor dysfunction. So the correct answer here is letter B. Safety risks due to unawareness of impairments and impulsivity. Okay? If you had answered letter C, problems with speaking and understanding language, where is this affecting mostly? The language deficits, the aphasia, are actually associated with the left hemisphere stroke. All right? Associated with left hemisphere, left-sided stroke. All right? Aphasia, understanding language. And if you had answered letter D, emotional issues like depression due to disability, is this something that you should select? Well, the depression is more common in the patient with the left hemisphere stroke as well. So we are going to list that in this section as well. Depression. Mood regulating areas is actually in the left side of the brain, left hemisphere. All right. So the correct answer in this test question, again, is letter B. All right. Guys, in review, for the person with a right-sided stroke, You are going to worry about their impulsiveness, climbing out of bed. Their judgment will be affected as to their safety. They will not be able to think that they are unsafe doing it, getting to the bathroom without help. They will not be able to understand their limitation. This is what we call as reduced spatial awareness. And along with the right-sided stroke, they will have left-sided hemiplegia because of the contralateral manifestation. However, if your patient has a left hemisphere stroke, they will have issues with the right side of the body. Motor function will be affected, and there's going to be issues with depression, with their emotion. They are not going to be able to really control that. Okay, so don't forget about the hemispheres, guys. Number 10. When managing a patient with a new right-sided visual field loss after a stroke, the nurse should A. use an eye patch on the right eye, B. approach the patient from the right, C. keep necessary items on the patient's left side, or D. explain that the left visual problem will improve. So what is your answer on number 10 rather? What is in number 10? When managing a patient with new right-sided visual field loss after a stroke, the nurse should right-sided visual field loss. That's basically going to be like this. When the patient is looking into that visual field, assuming this is the left eye, and this is the right eye. So the visual loss is right here, right-sided visual loss. So both the right eye and the left eye will have issues in this section of their visual field. What would be your answer this time? They will not be able to see the object, especially into the right visual field, either on the right or left eyes, or both. So they're not going to be able to see those objects on the right side because that is the field that they have a trouble with. Okay? So if you had answered letter A, use an eye patch on the right eye. Eye patch. So you're going to cover the patient's eye with a patch like Zuro. You're going to cover that with a patch. All the more the patient's visual field is covered on the right eye. They only have that vision on this one, on the left eye. So basically, when you're going to apply the eye patch on this letter A, it does not address the visual field cut. It can further restrict the patient's vision. So take note, guys, that the hemianopsia is affecting both eyes this time, not just the left eye. It's affecting the right side as well. All right? So, more restricted vision. So this is incorrect. If you're going to approach the patient from the right, this is also incorrect, because remember that their visual field is actually gone partially on each eye, especially to the right side. So we are going to eliminate that as well. You should approach the patient onto their left side. This is erroneous. Okay? So the correct answer here is to keep necessary items on the patient's left side. This visual field is still available on both the right and the left eye. Okay? So you are going to place those essential items, objects, onto the visual field that is not affected. It will enhance their safety and also their accessibility. All right? Now, if you had answered letter D, explain that the left visual problem will improve, this is false reassurance. There's no assurance that this is going to resolve? There's none. So your patient should be taught to do those techniques instead, because there's no guarantee that there's going to be an improvement. So what you should be doing here as a nurse for this patient is to teach techniques, how to improve their visual field. Teach techniques. So what are those techniques that you should be sharing to them? Make sure that they scan their visual field. They have to really turn their head. Make sure they're scanning the front side of their vision. Okay, make sure that they do that in order to really see those necessary objects if they're looking for them. All right, so make sure that you are being realistic in your teaching as well. Answer is letter C. All right, let's move forward with number 11. A patient uses their left hand and has left-sided paralysis, is struggling with feeding themselves. What should the nurse include in the care plan to help this patient? Let me reread. A patient who uses their left hand and has left-sided paralysis is struggling with feeding themselves. What should the nurse include in the care plan to help this patient? Is it A, offer a wide range of meal options? Or is it B, ensure oral hygiene is done before and after eating? During the treatment, can we patch the left? No, it's not also appropriate around that hemianopia. Remember that it's not just affecting one eye. It's affecting both eyes. All right. No patching will be needed for the homonymous hemianopia because it's affecting both eyes. It will also restrict their visual field. So let me reread the options here. Offer a wide range of meal options. B, ensure oral hygiene is done before and after eating. C, help the patient learn to use their right hand for eating. Or D, instruct the patient on how to do chin tuck eating or chin tuck while eating. So take your pick. You're welcome. Patient uses their left hand, has left-sided paralysis. Oh, poor boy. Left-sided paralysis, is struggling with feeding themselves. What should the nurse include in the care plan to help this patient? So I'm seeing your answers here. Letter C, help the patient learn to use their right hand for eating. Yeah. Of course, your patient already has an impaired left hand function. So why insist on having them use an impaired extremity? So the best way to help this patient out is to have them use the right hand for eating. They need to develop that skill, the right hand. Development of new skill, especially if they are left-handed, right? If their dominant side is the left, so they should be taught in developing a new skill, which is using the right hand for eating. Okay? It is most practical. This will be a means of adapting to the new limitation. Okay? Adaptation. And they should be learned. They should learn this in order that they can achieve independence in self-feeding. Okay? Teach this skill to promote independence. That is the reason that we should promote this new skill. If you had answered letter A, offer a wide range of meal options, will that be helpful to your patient? Meal options, really? It's not going to address the patient's difficulty with self-feeding this time because they have issues with the left side. Our goal in this test question is really to enhance their independence, not about having them choose meal options. This is not addressing that concern. Same thing with letter B. We know that oral hygiene is also important, right? Before and after, but it's not also addressing their need to be independent, especially that they are struggling using their left hand. So it does not solve the concern as well. Alrighty, what about letter D? Instruct the patient on how to do a chin tuck while eating. Yes, this is a technique, a good technique, especially if your patient has issues with aspiration. Guys, let me elaborate this letter D, chin tuck. This is a technique that we should be doing for a patient that has a stroke with aspiration risk. Used in stroke patients with aspiration risk. Most of the time when they are not taught on the proper technique, when they are given a pill and a cup of water to take a sip on, what they usually do is put the tablet on top of their tongue, and then they're gonna take a little sip of water, but they're gonna tilt their head backwards. This can actually cause aspiration to our patient. So the safe way to do the swallowing, or to promote the safety in this patient that has aspiration, what they should be doing is to get that pill, sit right on top of their tongue, have them take a little sip of water, but when they start to swallow, they should tuck their chin like that in order to close the airway. All right? That is the technique for those patients with aspiration precautions, or aspiration risk rather. So do the chin tuck. All right? Never let them do the neck extension. Have them do the neck flexion instead while swallowing. This is a technique that has been taught to us by the speech therapist. And I've always done this to all my elderly patients, because they are really known to have dysphagia. I always recommend this on my elderly clients. Alrighty, so a correct answer here is letter C. Now let's move forward to number 12. We still have a long ways to go, guys. What is the most effective way to prevent foot drop in a patient who has had a stroke and is paralyzed on one side? Is it A, position the patient's feet against a rigid footboard, or B, change the patient's position every 2 hours, or C, have the patient wear high top sneakers for parts of the day? D, regularly massage the patient's feet and ankles. So this is to be corrected, for the most part. For the most parts of the day. Let me correct that instead. We are on item number 1285. 1285. 1285. So what would be your answer here, guys? Preventing foot drop. Are you going to do letter A, position the patient's feet against a rigid footboard? Will that be a safe practice? This was known to be a best practice in the olden days, but not anymore. Not anymore. Rigid footboard against a rigid footboard, this can actually cause plantar flexion. So this is not the best practice, not any more effective. This was known to be a nursing intervention in the olden days, but not anymore because of the plantar flexion that it can cause. It can cause that contracture, which is what we have here, plantar flexion. Because it can stimulate the spasms rather than preventing them. So if you're answering letter B, change the patient's position every 2 hours, positioning them on their back, their sides, the right or the left side. Are you addressing the foot drop in this manner? Are you addressing? That's my question right now. It's not going to deal with the foot drop. The regular repositioning will only prevent the pressure source, but not the foot drop. Prevents pressure source. It's not gonna prevent the foot drop in our patient. We are eliminating letter B. What about letter D? Regularly massage the patient's feet and ankles. Regularly massage? Are you gonna be doing this for the most part of your shift? No, that's not realistic. Regularly massage? No, it is not going to prevent that foot drop. Massage can improve circulation. Yeah, that's the benefit. It can also promote comfort, but it does not promote or it does not prevent the foot drop. There is no impact in the muscle, or it doesn't have an impact on the tendon length to prevent plantar flexion contractures. All right, can promote comfort, but it doesn't really affect the plantar, or it doesn't prevent the plantar flexion. Okay. So we are eliminating letter D. We don't have any other answer, but letter C, have the patient wear high top sneakers for the most parts of the day. That is going to give support into the patient's feet. All right. The high top sneakers will actually prevent the foot drop. It will maintain a neutral position. It will prevent the foot drop. Maintains neutral position. Take note, guys, we are talking about high top sneakers. What if he has DM? Does high top? Okay, of course. You're not just going to leave those sneakers on for the day. You have to check for the skin integrity as well. You're not neglecting the skin check. The concern here is basically to prevent the foot drop. It doesn't mean that we are not going to do skin check. We are going to do that as part of the care. All right? So you're going to answer the test question as it is. What is being provided to you? Your answers are limited to what is given to you. Do not think outside of the options. Okay, you probably would be thinking of something else here, and this will complicate your decision making, especially in choosing those possible correct answers. So do not overthink, do not complicate things when you are not familiar what to do. Okay, so our correct answer here is letter C. Alrighty. For the most parts of the day. Again, your skin check should be at least every 8 hours. That is suffice. And of course, you're not going to have to put those ill-fitting shoes as well. You need to make sure that they are wearing the shoes that is well-fitted for them. Yeah, for the most part of the day, it doesn't mean that you are not checking their skin every 8 hours. It doesn't mean that you're going to put them on the whole time. You have to check the skin. Check for any blisters. Yeah. For the most parts of the day. It doesn't mean entire day. That's totally different statement. So don't play with the words. Number 13. How should a nurse position a stroke? How should a nurse position a stroke patient patient's arm and hand to avoid joint deformities? A. Place a pillow under the armpit to keep the arm away from the body. B. Use a pillow to elevate the arm slightly so the hand is above the elbow. C. Keep the arm immobilized in a sling. D. Use a hand cone to keep the finger slightly bent. And letter E. Position the arm against the side with a pillow. Oh, that's good, Chi-Chi. Yeah, there's way too many things to learn in neuro nursing. Some things that you don't even learn in the nursing school. Yeah, and it takes years to actually obtain all these skills. 2 years is not even enough. And people will consider themselves as expert already having worked in the neuro for 2 years. That's not even true. It takes several years to really master and be expert into that special area. So let's talk about number 13. How should a nurse position a stroke patient's arm and hand to avoid joint deformities? How are you going to deal with this patient? Basically wanting you to properly position to prevent the contractures, right? What will be that step? Or actually, this is a select all that apply. Wait a minute. This is a select all that apply. Select all that apply. Wait a minute. Let me correct this. Add that in the scenario. Number 1286. All right. Select all that apply. Okay, here we go. I hope that you are seeing this one right now. Yeah, SADA. Yeah, I just realized that because of the letter E. That extra option. So how should a nurse position a stroke patient's arm and hand to avoid joint deformities? Select all that apply. Will that be C, D, E? Let's take a look. What about letter A? Place a pillow under the armpit to keep the arm away from the body. Kind of like, what is this? Well, when you're going to position the pillow in the axilla or the armpit, it will maintain abduction. It will actually prevent the skin breakdown. That is the purpose why we are going to place a pillow under the armpit, to prevent breakdown of the skin. This will prevent friction between the skin surfaces. So it also will promote the alignment, and this will decrease the risk of the contracture. So our letter A is part of it. A pillow under the armpit. Okay. Now let's have letter B. Use a pillow to elevate the arm slightly so the hand is above the elbow. Use a pillow to elevate the arm slightly so the hand is above the elbow. Yeah. The elevation of the arm basically will prevent the edema, especially if there is going to be a need to promote venous return. You need to keep that arm in a functional position. So alignment is also maintained. All right. So that is part of the correct answer. Use a pillow to elevate the arm slightly so the hand is above the pillow. The reason for that is to promote venous return. Yeah, there's so many things that you have to keep in mind, especially in a stroke patient, guys. Let's have letter C. Keep the arm immobilized in a sling. Will this be applicable? Sling, placement, immobilization. Are you supposed to put a sling on this patient? This can actually cause stiffness and contracture formation, especially the shoulder. No immobilization required for this patient, guys. So we are going to eliminate this one. Leads to contractures. Eliminate that. What about letter D? Use a hand cone to keep the finger slightly bent. So maybe you're going to use maybe a piece of towel. We're going to have to roll it so their fingers are slightly bent. That is correct, right? Have you done this? You're going to roll a small piece of towel, like a washcloth or something, and then you're going to put that rolled towel, place that into the patient's hand so they can grab it. Yes, this is a good intervention in order to maintain a functional hand position. So letter D is basically one of those interventions. Hand cone. What about letter E? Position the arm against the side. Position the arm against the side with a pillow. So you are actually adducting the patient's arm. This is adduction, guys. Position the arm against the side with a pillow. This can promote adduction, which can lead to more contractures. Okay? Can lead to contractures and also skin breakdown. Contractures. Let me rewrite that. Wait a minute. Whoops. Contractures. Okay. And also skin breakdown. All right. So we do have our correct answers here. We have A, B, and D. Okay. This is abduction right here. All right. Please take note. Our correct answers for this item is letter A's, B, and D. Do not immobilize the patient's arm or shoulder using that sling, and do not cause adduction. This can lead to contractures as well. Well, let's have number 14 this time. When teaching the family of a patient with swallowing difficulties, which strategy should be included to reduce the risk of aspiration? Select all that apply. When teaching the family of a patient with swallowing difficulties, which strategy should be included to reduce the risk of aspiration? Select all that apply. Letter A, have the patient sit upright while eating. B, limit the diet to liquids until swallowing improves. Letter C, introduce food on the unaffected side of the mouth. Letter D, minimize distractions during meals. And letter E, serve food in large pieces for easier handling. Your patient has swallowing difficulties. Which strategy should be included to reduce the risk of aspiration? You're answering B, C, E, A, C, D. I'm not quite sure about ratio. Maybe you're answering a previous item. We are on item number 14 this time. So what would be those options? What are those techniques that can prevent the aspiration? All right, let's tackle this. Letter A, have the patient sit upright while eating. Yeah, of course, right? You're not going to put your patient in 30 degrees angle or 45. That's not going to keep them from choking. It's not going to prevent them from having that choking episode. So make sure that they are sitting upright. That is the recommendation that should prevent aspiration. 90 degrees. Back well supported. So these are things that you should be observing, guys, especially when you are dealing with elderly people. Back well supported, rather. When you are feeding those older individuals that they are higher risk for the aspirations, make sure that they have proper back support. Okay? Well supported. All right? Sitting upright. What about letter B? Limit the diet to liquids until swallowing improves. Will this be a good intervention? Limiting them to liquid diet. Actually, guys, when they have dysphagia, most of them will have difficulty in swallowing thin liquids, which can actually lead to the aspiration. So, liquids will not be highly advisable for this patient with high aspiration risk. Most of the time, thin liquids can cause aspiration. That's a red flag. What about letter C? Introduce food on the unaffected side of the mouth. Unaffected. Will this do the trick? Yeah. If the right side of the mouth is the paralyzed side, then you're going to have to place the food on the left side, right? So they can better control the movement of the food. This will reduce the risk of food entering into the airway. So this is a good intervention. Introduce food on the unaffected side of the mouth. What about here? Minimize distraction during meals. Yeah, of course. That is a good intervention. So what are those distractions? Guys, take note, guys. Pay attention. Minimize distractions. There are so many distractions that can happen in the care setting. What are this? Television. Shut the TV. Yeah. Also, visitors. If there are way too many people talking to the patient, this is already a distraction. Have at least one family member to stay and do not let them distract the patient while they are eating. That's another biggie, guys. Limit conversations. That's another technique in preventing the distractions. All right. Now, what about letter E? Serve food in large pieces for easier handling. Will this be helpful for your patient? Large pieces. Large pieces of food? No. This should be properly cut into small and manageable pieces. This is incorrect. So you should be serving the patient with small pieces. So, Melrose, you mentioned about nectar thick. Yes. One of the recommendations that could be possibly be given by the speech therapist will be modifying their intake of liquids. They're going to recommend the thickened liquids instead, not thin. Okay? So this is going to be erroneous. So our correct answers will be letters A, C, and letter D. Thickened liquids. This will prevent the aspiration. Alrighty. Let's have number 15. I got so many more. Actually, I have like 25, 24 questions today, but maybe we're going to have to cut this session earlier. Let's have number 15. For a stroke patient experiencing homonymous hemianopia, the nurse should expect the patient to A, crave salty foods more than before, B, only eat food on one half of their plate, C, struggle to remember food names, and letter D, have difficulty swallowing liquids. Take note, our case is on a patient with homonymous hemianopia. So what would be your expectation in this patient? Will they crave salty foods? Or are they only going to eat food on one half of their plate? Or will this be a struggle to remember food names? Or is it letter D, difficulty swallowing liquids? Okay. A plus answered letter B. Mary answered letter B as well. That is the correct answer. Letter B. Remember about that visual field loss? Half of the field is actually gone. So, The patient is expected to only consume half of their plate because of the blindness in the same half of the visual field. Okay? Blindness in half of the field. So, the left eye, the right eye, yeah, they will not be able to see entirely their plate. So they will not be consuming all the food items that is being served to them. All right. Now let's have letter C. Struggle to remember food names. Is that the problem with homonymous hemianopia? That's not it. Forgetting the names of foods is a sign of aphasia or not able to identify. So that is basically a language disorder. Language disorder, or it could be aphasia, but not homonymous hemianopia. If you had letter A, craves salty foods more than before, this is something that can happen to a patient. They might have changes in their taste sensation. They might have a preference for the salty foods, but it's not directly related to homonymous hemianopia. Not associated with the homonymous hemianopia. Same thing with letter D, have difficulty swallowing liquids. This is dysphagia, not related to homonymous hemianopia. Totally different manifestation. Okay, it's 12:02, my time. Are you still okay? Can we proceed with number 16? I can go on. For a patient with expressive aphasia, which nursing action would best aid in communication? Is it A, communicate with a patient by speaking slowly and in a louder voice? B, provide a picture board for the patient to indicate what they need? C, write down instructions for the patient to read? Or D, use short and simple sentences when speaking to the patient? For a patient with expressive aphasia, which nursing action would best aid in communication? A, communicate with the patient by speaking slowly and in a louder voice. B, provide a picture board for the patient to indicate what they need. C, write down instructions for the patient to read. And D, use short and simple sentences when speaking to the patient. Okay, so that yes, does that mean that we can proceed with the rest of the test items? We are 16 out of 24, so I think we can probably finish the 24 items. I made sure that I'm giving you more test items today. So you answered letter B, provide a picture board for the patient to indicate what they need. Yes, they have expressive aphasia. They will not be able to really talk. They will not be able to tell you what they wanted, right? So instead of having them talk, which is going to be ineffective, you're going to give them the picture board. They're just going to point into the picture board. There will be several sets of photos in there that might be helpful, clarifying what exactly they need. So that is letter B. Provide a picture board, especially when they have expressive aphasia. This will allow them to communicate what they need. So maybe they're going to point into a bathroom or a toilet if they need to go poo-poo. Or if they're pointing into a photo that is filled with water. Or are they pointing into a face that is very sad or maybe tearful, grimaced face? They are in pain. Yes, those photos will actually help them in communicating with you guys. All right, use the picture board. If you're going to give them a list of instructions for them to read, this is going to definitely not going to help them in having or collecting their response, because what we have as an issue here is their response. This is what causing the issue. All right, they will not be able to tell you exactly. So writing down the instructions is not what they need this time. What they need is to at least give them an alternative so they can point those photos that will be helpful in determining what they wanted. So this is incorrect. This is also incorrect. Communicate with the patient by speaking slowly in a louder voice. Really? Slowly can be helpful, but louder voice, not so much. Sometimes louder voice can mean being so rude to the patient. So you should not be doing this without assessing the patient's hearing ability first. Okay? Make sure that you should have them that available communicator board or photo board. Okay? Let's have number 17. Weeks after a stroke, a 55-year-old man has trouble recognizing when his bladder is full, leading to urinary incontinence. What should the nurse do to help the patient retrain his bladder effectively? Weeks after a stroke, a 55-year-old man has trouble recognizing when his bladder is full, leading to urinary incontinence. So what should the nurse do to help the patient retrain his bladder effectively? Will you do A, limit fluid intake to 1,200 mL to reduce urine production? I think we have this kind of question in the past, right? B, help the patient use the commode every 2 hours. Letter C, perform a bladder scan after each urination to check for leftover urine or residual urine. D, use a condom catheter to keep the skin dry and avoid embarrassment. We are retraining the patient. Bladder training is what we call it. Bladder training. And this type of questions really are very common in the NCLEX, mostly nursing care. So let's have the answer. The correct answer this time is letter B. Putting that schedule every 2 hours to the commode is actually helping them establish their toileting schedule. That is the correct answer. It establishes routine. And also, it will lead to bladder fullness awareness. Bladder awareness. So, somehow, it will lead them to think, hey, I think it's time for me to pee right now. Yeah, I need to do this because I'm reminded to sit on the toilet or I'm reminded to use the urinal. So, it actually will establish that routine. It will reduce the incontinence. Okay? If you had answered letter A, limiting fluid intake to 1,200 mLs, this is going to lead to dehydration, guys. 1,200 mLs is not enough in 24 hours. That is so little, guys. It can lead to the dehydration and so many other complications. Your patient probably will end up with a urinary tract infection because they're not flushing their urinary system. That's a poor nursing care. Let's have letter C, perform a bladder scan after each urination to check for leftover urine. The action is good, but the question is, will it establish a routine? No, it doesn't. So we are eliminating this one. We are only checking for the residual urine, but it will not establish the routine. So it will not be helpful. Letter D, use a condom catheter to keep the skin dry. Yeah, you're only worried here about the skin issue. It's not addressing the patient's incontinence. So this is wrong. Only focused on skin integrity. That is not what this question is all about. The question is to address the patient's urinary incontinence. And to manage that is to establish a routine, and that is letter B. Establish routine. That is a goal. All right, I hope that you're learning. Number 18, let's move forward. A patient is attempting oral feeding for the first time after experiencing a stroke. After assessing the gag reflex, what should the nurse do next? A, order a diet consisting of pureed foods. B, check the patient's appetite levels. C, assist the patient to sit in a chair. D, offer the patient a small sip of juice. A patient is attempting oral feeding for the first time after experiencing a stroke. After assessing the gag reflex, what should the nurse do next? Will you do A? Will you do B? Or C? Or letter D? The question, or actually the clue that you should have this time, is to select that nursing action that will consider the swallowing ability of our patient. Those nursing interventions that can promote safety of our patient. So, if you had selected letter A, order a diet consisting of pureed foods, will this be appropriate? We know that pureed foods can be sometimes way too smooth, right? It can be somewhat harder for them to manage, especially with those patients with swallowing difficulties. Diet consisting of pureed foods. Okay? Compare it to, what about having letter C instead? Assist the patient to sit on a chair. Think about the aspiration precautions. Oh boy. Promote safety. You got to make sure that your patient is sitting upright. And also, the back is well supported. Well supported back. Okay? That is the goal here. We want to maintain the safety of our patient by allowing them to sit on a chair or in a chair, not on the bed. This is not going to make them at ease, especially this is not the norm, guys. Sitting on the chair, sitting at the edge of the bed will not be safe. If you're going to assist them to sit on a chair or in a chair, this will keep them in an upright position, and this is very crucial in reducing the risk of aspiration. You got to make sure that their back is well supported and make sure that they can proceed with the first meal with proper support. Okay? If you had answered letter B, check the patient's appetite levels. Yeah, that is also important, but it's not going to promote safety, especially in a patient that is now resuming the first time. They are now resuming their first meal, right? So you got to be careful at this point. Your patient can do a lot of weird things. So make sure you maintain their safety. If you're going to offer the patient with a small sip of juice, it's pretty much the same as letter A. It's not going to keep them safe. The juice is actually a thin liquid. It can be challenging to the patient as well for those patients that may have a dysphagia, and most often they will. So our patient will be at risk to developing the aspiration. So guys, keep your patient at safe, in a safety mode, in making sure that they are in the right position. Number 19, a patient has a ruptured cerebral aneurysm leading to subarachnoid bleeding. What should the nurse include in the patient's care plan? Here we go, subarachnoid bleeding. Finally, are you going to apply pneumatic compression device intermittently? Or are you going to help the patient sit on the edge of the bed and watch for dizziness? Or are you going to encourage the patient to cough and take deep breaths regularly? Or is it D, insert an oral airway to prevent blockage? Take note, your patient has cerebral aneurysm bleeding, ruptured, bleeding, aneurysm. So what should you do in this patient? Will you do the application of the pneumatic compression device? Or will you help the patient sit on the edge of the bed and watch for dizziness? Guys, your patient here is with subarachnoid bleeding, and the ICP is high this time. What do you think can prevent any complications here? Increased ICP, and the patient will be prone to developing other complications as well, like DVT. So what would you do to curate the patient's care plan? If you answered letter D, insert an oral airway to prevent blockage, our patient is not found to be unconscious this time. So if you're answering inserting an oral airway, it's not really figuring out. It's not going to prevent any complications. The oropharyngeal airway is not indicated unless they are unconscious. Okay? Guys, take note about the oral airway. Indicated when patient is unconscious. Not all patients with subarachnoid bleeding can be unconscious. Some of them are actually going to be awake still. There is no mention that the patient is unconscious. We don't have that information. So if we are going to do this, letter D, it's not really addressing the issue. What if we answered letter C, encourage the patient to cough and take deep breaths regularly? Guys, our patient with the subarachnoid bleeding has increased ICP. Coughing can lead to increased ICP. Increases ICP. Do not let them do the coughing exercises. All right, no coughing. What about letter B? Help the patient sit on the edge of the bed and watch for dizziness. Will this help? Guys, the patient here, if you're going to put them on the side of the edge of the bed, this is already an activity that can increase the ICP. Enough to cause increase in ICP. The movement is enough to cause that. So the patient should be kept in bed around this time to prevent rise in the ICP. What you're going to do here instead is to apply the pneumatic compression device intermittently. And the reason for that is to prevent DVT. That is the correct answer. Our patient, while they are in bed, they're going to be at a higher risk to developing the deep vein thrombosis. And to combat that, we have to apply those SCDs. Are you familiar with the SCDs, those leg squeezers? Sequential compression device. Are you familiar with this? These are those materials that can be wrapped around the patient's thighs, the legs, and this is an electronic device that can introduce air into those wraps, and it will intermittently compress the leg. It will kind of massage. It will promote circulation of the blood. So that's what we call a sequential compression device. So that is what we are looking for in this item. Now, finally, we have number 20. This will be our last question of the day. A patient with a history of transient ischemic attack is prescribed 160 milligrams of aspirin daily. The patient refuses the aspirin, saying they don't have a fever. How should the nurse respond? Guys, take note about the dose here. Again, it can vary from one patient to the next. Maybe they can be given a dose of 81 milligrams or baby aspirin, or maybe 160, or maybe 320. So it depends. So let's proceed with this question. The patient refuses the aspirin, saying they don't have a fever. How should the nurse respond? Is it A, note the patient's refusal of the aspirin in the chart? B, tell the patient that aspirin is given to prevent fever? C, explain to the patient that aspirin helps reduce the risk of stroke? And letter D, contact the healthcare provider to confirm the aspirin order. So your patient is prescribed 160 milligrams of daily aspirin. They are refusing because they say that they don't have a fever. So how are you going to tell the patient? Mary answered letter C, explain to the patient that aspirin helps reduce the risk of stroke. Yes, that is the correct answer. Remember about the antiplatelet property. That is the main reason. To prevent clots. Okay? That is the correct answer. Why they are placed on the aspirin daily. Okay? If you had answered letter A, note the patient's refusal of the aspirin in the chart. Basically, what you're doing here as a nurse, you're only documenting, but you did not address the patient's understanding. Poor nursing. Why poor? Because you are not giving them the education. Did not educate the patient. That is wrong. Tell the patient that aspirin is given to prevent fever. No, that is not the reason why we are giving them the aspirin. The reason that we are giving them aspirin is to prevent the thrombosis, the formation of the blood clots. We are preventing them from having another stroke. All right? What about letter D? Contact the healthcare provider to confirm the aspirin order. Is there really a need for us to confirm? This time the medical provider will be mad at you. There is no need to clarify the aspirin order. It is a standard practice for preventing strokes, especially in a patient that has transient ischemic attack. There is no need. All right. But if the scenario stated something, if the scenario said something about give oral aspirin, maybe, what was the dose again? 160 milligrams. And if they had a known dysphagia, or let's say they are not able to really take in the medication safely, then you can question that. You need to verify the order, maybe convert it into a rectal aspirin. That is possible. But as far as the question itself, we are limited to what is given to us. There should be no question regarding this order. It's not an erroneous type of order. This is an expected treatment, especially in a patient with a TIA. All right. So that is letter C. Guys, that's the end of our lecture or discussion today. So I hope that you're learning. And again, I'll see you tomorrow at 9 p.m. Eastern Standard Time. So I'll expect for you to be more active in our exercises, and hopefully you have gained more understanding regarding stroke care. This is very important. So again, guys, thank you. You all take care, and have a great evening, morning, afternoon, wherever you are. You got to take care. Bye-bye.